Body dysmorphic disorder is a mental health condition. Look at this picture shows that repetitive mirror checking and grooming behaviors and experience anxiety, depression. Look at this detail going on. Introduction. Body dysmorphic disorder is a severe mental health condition where individuals obsess over perceived flaws in their appearance. These flaws may be minor or non existent but cause significant emotional distress and impact daily functioning. The disorder affects both men and women and can lead to social withdrawal, depression, and even suicidal thoughts. A definition: BDD is defined as a mental health disorder characterized by excessive preoccupation with perceived defects or flaws in physical appearance, which are often unnoticeable to others. This preoccupation leads to repetitive behaviors such as mirror checking, excessive grooming, and seeking reassurance. Etymology. The term body dysmorphic disorder comes from the Greek word dysmorphia, meaning mishappiness or malformation, combined with disorder to indicate a psychological condition. It was first described in medical literature in the late 19th century but gained recognition as a distinct mental health disorder in the late 20th century. Types: 1. Muscle dysmorphia, a subtype where individuals, often men, believe their muscles are too small or not well developed. 2. Facial dysmorphia, a preoccupation with facial features such as nose shape, skin texture, or asymmetry. 3. Skin dysmorphia, an obsession with acne, scars, or complexion. 4. Hair dysmorphia involves concerns about their thinning or baldness. 5. Overall body dysmorphia, general dissatisfaction with body shape or size. Causes: 1. Genetic factors, family history of BDD or obsessive compulsive disorder. 2. Neurobiological factors, abnormalities in brain structure and neurotransmitter function. 3. Psychological factors, childhood trauma, bullying, or low self esteem. 4. Sociocultural influences, media, portrayal, or ideal beauty standards. 5. Personality traits, perfectionism, anxiety, and heightened self consciousness. Risk factors: 1. Family history of BDD or mental disorders. 2. History of childhood neglect or abuse. 3. Social isolation. 4. Low self esteem. 5. Pressure to meet societal beauty standards. 6. Coexisting disorders such as depression, OCD, or anxiety disorders. Complications: 1. Severe emotional distresses and depression. 2. Social withdrawal and isolation. 3. Suicidal ideation or attempts. 4. Repeated cosmetic procedures or surgeries. 5. Occupational or academic impairment. 6. Substance abuse. Pathophysiology: BDD associated with dysfunction in the phalangostructural circuits, particularly in the orbitophalangeal cortex and caudate nucleus, which are involved in obsessive thoughts and compulsive behaviors. Serotonin dysfunctions has also been implicated as selective serotonin reuptake inhibitors (SSRIs) are often effective in treatment. Here is a step-by-step breakdown of its pathophysiology. 1. Genetic and neurobiological basis. 2. Neurotransmitter dysregulation, serotonin imbalance, dopamine abnormalities, glutamate dysfunction. 3. Abnormal visual process. 4. Cognitive emotional dysfunction, negative cognitive biases, emotional dysregulation, maladaptive perfectionism. 5. Behavioral manifestations. Compulsive behaviors, avoidance behaviors, cosmetic procedures. 6. Environmental and psychological triggers. Early life experiences including bullying, teasing, or trauma can contribute. Societal pressure and media influence reinforce. Unrealistic beauty standards, childhood abuse or neglect may lead to heightened self criticism and body dissatisfaction. 7. Chronicity and comorbidity. BDD is often chronic, worsening without treatment. High comorbidity with OCD, depression, anxiety disorders, and eating disorders. Increased risk of suicide due to severe distress and functional impairment. BDD results from a interplay of genetics, neurobiology, cognitive distractions, and environmental influences, leading to obsessive focus on perceived flaws, emotional distress, and compulsive behaviors. Treatment typically involves cognitive behavioral therapy (CBT), selective serotonin uptake inhibitors, and sometimes antipsychotic for severe cases. Signs and symptoms. 1. Excessive concern over perceived physical flaws. 2. Frequent mirror checking or avoidance. 3. Repetitive grooming behaviors. 4. Seeking reassurance from others. 5. Excessive use of makeup or clothing to hide perceived flaws. 6. Anxiety, depression, and suicidal thoughts. 7. Avoidance of social situations. A diagnosis. Diagnosis in primarily clinical based on DSM-5 criteria. 1. Preoccupation with one or more perceived defects in appearance. 2. Repetitive behaviors or mental acts related to appearance concerns. 3. Significant distress or impairment in social, occupational, or other areas. 4. The symptoms are not better explained by an eating disorder. Nursing diagnosis. 1. Disturbed body image related to negative self perception. 2. Ineffective coping related to obsessive thought about appearance. 3. Social isolation related to self consciousness and embarrassment. Medical management. 1. Psychopharmacological. SSR help reduce obsessive thoughts and compulsive behaviors. 2. Cognitive behavioral therapy. Gold standard treatment focusing on altering negative thought patterns. 3. Antipsychotics. If delusional belief are present. Nursing management. 1. Establish a therapeutic relationship based on trust and empathy. To encourage open communication and self expression. 3. Educate about BDD and treatment options. 4. Help patients develop healthy coping strategies. 5. Monitor for suicidal ideation and intervene appropriately. Treatment options. 1. Cognitive behavioral therapy focus on modifying distorted thinking patterns. 2. Medication. SSRs, antidepressants helps manage obsessive thoughts and depressive symptoms. 3. Exposure and responsive prevention ERP, a form of CBT that reduces compulsive behavior. 4. Mindfulness and relaxation techniques reduce anxiety and enhance self acceptance. 5. Support groups and peer counseling encourages shared experiences and coping strategies. Psychosocial medicine. 1. Psycho education, educating patients and families about BDD. 2. Cognitive restructuring, challenging and replacing negative thoughts. 3. Social skill trainings, improving communication and interpersonal skills. 4. Behavioral activation, encouraging participation in meaningful activities. 5. Family therapy, involving family members to provide support and reduce enabling behaviors. Prevention. 1. Promoting positive body image through self acceptance. 2. Reducing exposure to unrealistic beauty standards in social media. 3. Early intervention for those at risk of developing BDD. 4. Enhancing coping mechanisms to manage stress and anxiety. 5. Raising awareness in schools and communities to destigmatize mental health. In conclusion, body dysmorphic disorder is a severe mental health condition that can significantly impact on individuals' quality of life. Early recognition, appropriate interventions, and support from healthcare providers, families, and society are essential in managing the disorder. With proper treatment and psychosocial interventions, individuals with BDD can lead healthier, more fulfilling lives. Thank you. Have a nice day.